Welcome to What Happened at ASH, the American Society of Hematology meetings in December 2025, immune thrombocytopenia. Are we entering a new age of treatment of this entity, specifically the use of BTK inhibitors and BAFF-R antagonists, B-cell activating factor receptor antagonists? This is medical oncologist Dr. Neil Love. I met with Dr. Hanny Al-Samkari from the Massachusetts General Hospital in Boston. When this final issue of our four-part series, Dr. Al-Samkari again responds to a series of cases presented by community-based oncologists, Drs. Tina Bhatnagar from Wheeling, West Virginia, Susmita Apuri from Iverness and Lecanto, Florida, and Sunil Gandhi, also from Lecanto, Florida. The first case was presented by Dr. Bhatnagar.
He was initially managed with pulse dexamethasone at a dose of 40 milligrams daily and then received 2 IVIG infusions, but his platelet counts didn't really respond. He's a young guy. He has a 3-year-old at home and was wanting to get discharged as soon as possible. So in the hospital, we kind of, bombarded him with additional ITP-directed therapies consisting of rimiplostim, and he also received 4 days of pulse dexamethasone, and then we restarted prednisone at a dose of 1 milligram per kilogram, and he also initiated rituximab while he was an inpatient, and subsequently his counts did improve, going from 4,000 to eventually 187,000 by the end of the month. He finished 4 weekly treatments of rituximab. We were able to taper him off prednisone, and he's currently not on anything for ITP. He did, however, have some persistent anemia, and amidst that workup was found to have a TSH of 124 and an undetectable free T4. He started levothyroxine, and his anemia improved and is now near normal at 12.8 grams per deciliter. So my question to the experts is what their threshold is for doing platelet transfusions. Would also love to know thoughts on how this could have been managed differently or alternatively. And I'm assuming that the ITP may have been related to his thyroid disease, which is probably also autoimmune. But if there are any other additional long-term considerations that they would take into account when monitoring this patient for relapse, he's doing very well currently.
So who likes ITP hostages in the hospital, right? Everybody wants to get the patient out of the hospital. The patient wants to get out of the hospital. This is a young guy, 3-year-old at home. He's got a life. You got to get back to that life. And so it's perfectly reasonable if someone is, sort of stuck in the hospital, not responding to typical first-line therapies, to throw on rimiplostim. I do it all the time, trying to get a patient out of the hospital as quickly as possible. The one thing you got to look out for, right, if you give a patient Dex and you give them IVIG and you give them, a high dose of rimiplostim, right, you might get some thrombocytosis, right? So you just have to be a little bit, wary of that possibility. Chances that they have any issue related to that are low, but it's always something to just think about. But I would say that it's okay to, particularly in people that don't respond to corticosteroids and IVIG in that early phase in the first few days, to add on TPRA, rimiplostim 5 milligram or microgram per kilogram. This guy also ultimately finished rituximab and has currently been off of ITP therapy for some time, hopefully for a long time. We'll see what ends up happening. If he relapses, I would not give him rituximab. I would give him, either a thrombopoietin receptor agonist for long-term use, or something like rilzabrutinib or fostamatinib. Let's see. The other question here is, what's the threshold for doing platelet transfusions? I only use platelet transfusions in people who are actively bleeding with significant internal bleeding. And it's not an easy thing, because one of the things we know about giving platelet transfusion is you're giving a big bolus of colloid. And when you do that, if someone has a brain bleed and that brain bleed is not being intervened on, you can increase the pressure in those ruptured vessels in the head, and that can make the bleed worse, right? You can increase hydrostatic pressure by giving big boluses of colloid. So when I do it, I give the platelets very slowly, and I will give IVIG to try to actually allow the person to respond to the platelet transfusion, to have a higher likelihood of response. And I won't go nuts. I'm not going to give them 2, 3, 4, 5 units trying to hit an arbitrary goal of 50,000 or 70,000 or whatever that sometimes we try to achieve, or sometimes proceduralists want us to achieve. Right? I'm using it primarily to achieve hemostasis. I want to see things stopping and the bleeding getting better. And I would also reach for tranexamic acid or aminocaproic acid infusion as an antifibrinolytic at the same time or before I reach for a platelet transfusion to try to get that bleeding to stop.
Any thoughts about her thought that this ITP might be tied into the thyroid issue? And what do you see with people? You hear about their thyroids, quote, burning out, but does the autoimmune process stop? Is the ITP usually temporary, or can you see relapses?
It's a great question. It's extremely common to see ITP concurrent or following autoimmune thyroid disease. Totally. Very, very common. Patients with ITP very commonly have anti-thyroid peroxidase antibodies, even if they don't have thyroid disease. The natural history of the two diseases tends to be separate. So even if someone's thyroid disease is getting better or burning out, their ITP might be ramping up. Typically, they don't tend to run together. Obviously, every patient is different, but they typically don't tend to run together.
So Dr. Apori has a really interesting case. I'm curious what you think.
81-year-old Caucasian woman, she has underlying COPD, and she did present with progressive shortness of breath that led to a CT scan, which showed a left-sided pleural effusion. She underwent a thoracentesis, and the pleural fluid was consistent with metastatic adenocarcinoma of the left lung. And this was almost 3 years ago. She came to me in a wheelchair. I still remember asking if she should go to hospice. So she was initiated on carboplatin, pemetrexed, and pembrolizumab. She did relatively well despite her COPD, and she was started on maintenance immunotherapy. And while she was undergoing immunotherapy, she presented with an acute thrombocytopenia and very mild anemia, and the platelet count was 21,000. And her platelet count was consistently above 150,000 all along while she was on immunotherapy. I did treat her with steroids. There was a very brief response. The platelets went up to 40,000. But as soon as I tapered up the steroids, they would come back to under 10,000. So during this time, the immunotherapy was held. The bone marrow biopsy did show a normocellular marrow with trilineage hematopoiesis, and the megakaryocytes are preserved. And there was really no evidence of hemolysis or PNH in the peripheral blood. So I did initiate her on L-thrombopag, I think only out of the thought process that I want her to complete her maintenance immunotherapy. She did very well on the L-thrombopag, and I changed the treatment to 3 times a week. Her platelets were consistently above 50K, and she completed the immunotherapy. And I discontinued the L-thrombopag because I said, let's see, what happens. She's done very well, and she's not really symptomatic with the thrombocytopenia anymore. So she's been off the L-thrombopag now for over 6 months, and her platelets were consistently above 100K. So my question to the experts with how often do you see immunotherapy-induced thrombocytopenia? This is my first case, and I have given my fair share of immunotherapy to our patients. How would you treat this patient? Would you leave them on the L-thrombopag and taper it down slowly? Because her current platelet count after 6 months is now trending in the 80s and 90s. So there has been a drop over time, but really not a significant enough drop for me to reinitiate any therapy. And in these individuals who develop the thrombocytopenia, how often do you see a recurrence?
So whenever you see an immune checkpoint inhibitor related hematologic complication like ITP or autoimmune hemolytic anemia, my number one goal, in addition to obviously managing the acute cytopenia issue, is getting that patient back on their IO, especially if they're responding really well to the immune checkpoint blockade. In this case, right, the patient responded beautifully to it, and you want to be able to continue it. And so, immune checkpoint inhibitor induced ITP happens in about 1 in 400 patients, as was very nicely shown by my colleague, Dr. Karp Leaf's abstract of ICI ITP presented at ASH that really showed, this was a big study of a lot of patients from many large cancer centers. You need a very large population in order to have enough patients to really analyze. And it showed that, most patients recover. And you can use steroids, you can use IVIG, you can use TPORAs. The response rates are relatively similar. Most patients recover. And when you re-challenge, most patients don't relapse with the ICI ITP when you re-challenge with the immune checkpoint blockade. So that's always my goal. Right, you can have really bad ITP. I've had patients that have had ICI ITP that's been more challenging to treat, but I've never had a circumstance where I haven't been able to get them back on their immune checkpoint blockade and maintain a reasonable platelet count. Sometimes, right, the cytotoxic chemotherapy may have to go by the wayside, or it may need to be dose reduced or what have you, if their ICI ITP is particularly challenging to treat. But for the immunotherapy, we generally are able to get that back on board and keep it on board. And this study, again, showed that we can be quite successful in managing it. It does, however, portend an overall worse diagnosis for the patient, right? This study showed that the patients that had more severe ICI ITP had more mortality after controlling for all of the oncologic, related issues, the tumor type, the stage, all the relevant things. So, we don't want to see it happen, but when we see it happen, we can manage it.
So let's hear what you think about this case from Dr. Gandhi.
78, he was diagnosed 30 years ago when he presented with large bruise on the face. Platelet count was 1,000, classical ITP. He moved to our town in 2021. I gave him rituximab and prednisone, but his ITP was minimally responsive to that regimen. So in August 2023, I put him on avatrombopag. He responded. He is in complete remission. His platelet count went up to even 200,000, 250,000. So I'm gradually reducing the dose. It is 20 milligram 4 days a week, and I'm trying to make it much less. Because this is one drug that studies are you can give on once a week. So my goal is if I can go to once a week and maintain it. But I'm using avatrombopag quite often. Question is, am I using right drug or I should be using another drug? One another thing is, say you are in a hospital round, you see another patient with 1,000 platelet ITP, and you want to start, should we go with high-dose steroid like prednisone 1 to 2 milligram per kg or dexamethasone 40 milligram for 4 days? And another question is in newly diagnosed ITP, when we usually start with steroid, should you put rituximab in all of them or most of them?
So the first question, you definitely are using the right drug, right? This patient has challenging ITP and has responded beautifully to avatrombopag, and you're lowering the overall drug exposure. With avatrombopag, it's done by reducing the number of pills the person takes per week. This is only one pill strength, unlike L-trombopag, which you can get 75, 50, 25, 12.5. Avatrombopag is just 20 milligram pills. And so you go from 7 days a week to 5 days a week to 4 days a week. You can go all the way down to 1 day a week. And some patients, they need that whiff of avatrombopag. They need that just a little bit in order to prevent them from crashing. So you definitely are using the right drug. And I think that it is appropriate to continue to try to slowly wean him down. And if he maintains a platelet count above 100,000, you could try to wean him off and see if he has a sustained response off treatment. But if you're getting, into that 30 to 50,000 range after lowering his dose, then I would probably just stick to whatever dose you're at when he gets to that 30 to 50,000 range.
What about his question there about rituximab and when you include it with corticosteroids up front?
I don't use a lot of rituximab up front with corticosteroids. I will say that it is coming in the updated ASH guidelines for ITP that you can consider doing that combination therapy. It's my main concern with rituximab is that I know it's not disease modifying, and I know that there's some nice data that has been published in people with ITP spleens after they get rituximab and compared to patients who have not gotten rituximab, and it may actually make the autoimmune response more recalcitrant. So I try not to do it. I actually really primarily reach for rituximab more in the salvage setting myself, right? It is off-label for ITP. It's perfectly reasonable to use, and the guidelines recommend it as a therapeutic option. And there's good data to suggest, to support its clinical use. But at the same time, I'm not curing anybody with this drug, and I may be making things a little bit more challenging in terms of down the road. So I try not to reach for it, and I except in kind of later line settings.
So, final question about this case. Looking back to when this patient was started on avatrombopag, when you think about that situation, if you had L-trombopag plus ianalumab available, would you have used that?
Yeah, this is a circumstance where it's somebody who had already gotten rituximab, so a little bit different than the VAY-HIT2 kind of situation. But I think that even though it's not exactly the same, I would have offered it to the patient, right? And it wouldn't necessarily have to be with L-trombopag either, right? The data is with L-trombopag, but once we have ianalumab in clinical practice, I would not hesitate to combine it with other TPO-RAs because they function similarly as a short course of TPO-RA, getting you to the point where you can be off of all therapy after giving the ianalumab with it. But yeah, I think that's something I would offer to this patient too, particularly given that he has very chronic disease. He's been he's had ITP for a very, very long period of time, and he might benefit from a very potent combination type approach.
I never thought to ask you this because I assumed you would say no, but so you're saying if you had ianalumab available, you might combine it with another TPO other than L-trombopag?
Yeah, I would. L-trombopag is a perfectly reasonable drug to use, and obviously the clinical trials used it. But L-trombopag, right, has dietary restrictions associated with it. You basically need to be fasted for 4 to 6 hours around taking it in order for it to absorb properly. It causes hepatotoxicity in about 10% of people who take it. In high doses, it can cause some muddying of the sclera and the skin, where people have almost like a darkening of their eyes, and if they're fair complexion, their skin, and that can be undesirable for some patients. So all of these things are things that avatrombopag and riblistim don't have. Right. So in practice these days, the oral TPO-RA that most patients prefer to use is avatrombopag because it's easier to take, and you don't have to monitor LFTs for a year, and you don't have to worry about the dietary stuff.
That's really great. We just got back from the San Antonio Breast Cancer Symposium. They're very, I don't know, Talmudic according to the book. If there's a lot of trials now with CDK inhibitors and SERDs. But, there's one study that has a specific CDK, abemaciclib, a specific SERD, imlunestrant, and that's all people, and it's we'll use. It's very interesting that you kind of have a different approach to it. Really makes a lot of sense, though.
With TPO-RAs, we have a lot of experience. We know that in many ways the efficacy piece, right, is interchangeable. It's just the tolerability and the mode of administration that makes the difference for some patients.
So let's hear about this final case from Dr. Botniger.
I have an 82-year-old woman who actually has numerous medical comorbidities, including heart failure, COPD, type 2 diabetes, hypertension, hyperlipidemia, COPD, and stage 4 CKD. She has a long-standing history of moderate ITP with platelet counts ranging between 40 to 50K. She had been following with a separate oncologist who was managing her basically with steroids during acute exacerbations, but really no other interventions. I met her as an inpatient when she was there for confusion and fluid overload as a result of a CHF exacerbation. And at that time, her platelet count was 19,000. Historically, she's had immense difficulty tolerating steroids as a result of their toxicities. I was concerned of the risk of exacerbation of cardiac comorbidities with L-trombopag, so I started her on fostamatinib, 100 milligrams twice a day. And within 2 weeks, her platelet counts improved from 9,000 to 114,000. And for the rest of her treatment course, she stayed between 80 to 100,000, really with no significant toxicities. So my question is whether the experts can comment on the advantages of fostamatinib and in which clinical situations they generally use it, and are there any special treatment considerations when choosing this drug?
Did she ever get IVIG or rituximab?
She never did. I thought it might just be easier from a logistical standpoint for her to take a pill rather than come in for infusions.
So this is a great example of how fostamatinib as a spleen tyrosine kinase inhibitor can be very useful in some patients with ITP. This patient responded beautifully, relatively quickly. Recognize that, right, with fostamatinib, you start at 100 milligrams twice a day, but you definitely want to up titrate to 150 milligram twice a day if you don't have an adequate response at the end of 1 month. Sometimes, right, you can quit prematurely, so it's important not to do that. Try the higher dose if they don't respond to the lower dose. This patient didn't need a higher dose. They responded very nicely to the lower dose and got platelets really at goal and really consistently there. This is exactly what we want when we start a patient on fostamatinib. So the question is, what are the advantages of fostamatinib? Fostamatinib, it has no theoretical thromboembolic risk like TPORAs have a theoretical thromboembolic risk. And in this case, right, the concerns about the patient's cardiac status were center stage, and that led to avoiding a drug like L-trombopag, avoiding a TPORA because of that risk. Fostamatinib may actually be anti-thrombotic. It actually may reduce the risk of thromboembolism, as has been suggested in some basic science studies. The patients who respond to fostamatinib tend to be very stable on their drug and can continue for very long periods of time with little challenge, and that's great. Fostamatinib is associated with a fair burden of side effects in some patients. Not in this patient, thankfully, but it causes a decent amount of hypertension. About a quarter to a third of patients will get hypertension. Sometimes that hypertension is pretty significant and requires multiple antihypertensives to treat. Patients, it's tyrosine kinase inhibitor. Patients get diarrhea. They can get rash, sort of other TKI type adverse events. But when it works well and the patients don't have concerning side effects, it can be exactly what you need. And that was a really good example in this case.
What about rilzabrutinib in a patient like this?
I think rilzabrutinib would have been a great option in a patient like this for similar reasons, right? Being able to potentially avoid a TPORA in an older patient with a lot of cardiac disease. Rilzabrutinib, when people respond, they tend to respond with pretty good, stable platelet counts. And overall, right, the side effect burden of rilzabrutinib, I would say, is less than fostamatinib. Obviously, it didn't matter for this patient. They responded great to fostamatinib without side effects. But I would have certainly considered rilza here as well.
What about ianalumab, single agent?
Yeah, if ianalumab was available, then I think that would also be another consideration here. This is somebody who, if they're on chronic antiplatelet or anticoagulant therapy as related to their cardiac disease, and there's a lot of concern about, definitely wanting to avoid the potential for the treatment effect wearing off of an episodic treatment, I might be more likely to reach for Rilza or Fosta than Ianalumab in someone like this, but certainly an option.
This concludes our program. Special thanks to Dr. Al-Samkari, and thank you for listening. This is Dr. Neil Love for What Happened at ASH 2025 ITP edition.